we get to the voting, when we get to the voting parts, we'll just make sure that we have a quorum. So good morning, everyone. My name is Stan Hamill. I'm the co-chair of the Behavioral Health Committee for the Incarceration Prevention and Reduction Task Force. Today, we are having a joint Behavioral Health and Legal and Justice Systems Committee meeting on December 14th, 2021. And before we begin, I'd like to provide a land acknowledgement statement. We acknowledge that we are gathered on the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at all and any public events. And I'm going to turn it over to co-chair, I guess, Raylene King from the Legal and Justice Systems Subcommittee.
Good morning, I'm Raylene King. I'm the court administrator for the city of Blaine and small cities representative. We have a couple guests here today, so I would ask that everybody here today, please announce your name and who you're with when you're asking questions. It's also good for the record for Jill's purposes. I would like to thank everybody for coming today to our virtual joint meeting of the Behavioral Health and Legal and Justice Subcommittee of the Incarceration Task Force. I would like to introduce some of our panelists for today's meeting. Joining us from Washington State Department of Social and Health Services is Darla Dawson. She is a Central Forensic Admissions Coordination for the Office of Forensic and Mental Health Systems. I also see that Susan Copeland has joined us. I didn't know if she was going to make it or not, but she is the Director of Residential Treatment Facilities and Behavioral Health Administration Office of Forensic and Mental Health Services. We also have joining us today Attorney Thomas Leiden with Keating and Leiden. Attorney Leiden is the Public Defense Counsel for the City of Ferndale and has served as pro tem judge in many of the small cities as well as the city of Bellingham. And Attorney Jason Smith is the lead attorney and owner of North County Public Defense, who represents the courts of limited jurisdiction in Whatcom County with the exception of Ferndale. Attorney Smith has also served as pro tem judge in many of the small cities in Whatcom County. There is a lot on the agenda today, and much of it will intertwine with each other. I believe many of the topics discussed will be separated into the committees and then merge back together in the next joint meeting. I think we'll be only scratching the surface today, but look forward to a great meeting and lots of information. We will be looking at what services are in place and what is missing, as well as solutions or resolutions for fixing the gaps in the system. We also want to look at other areas and best practices in reentry and jail navigations. This is especially pertinent to those who have competency evaluations and restorations. We want to look at recidivism rates of those who have been found incompetent or have been restored and then reoffend, to see where we need to go and what we can do to solve some of the problems. So we are kind of going out of order because we're going to kind of start with restoration and competency. And I would like to invite either Darla or Darla Dawson or Susan Copeland to let us know more of what their positions are, what they do, and problems that they see in the system. I see Darla has popped on, so I'm going to start with her and then like to open it up to questions. And I'd like to also hear from our panelist attorneys that have joined us on problems and questions that they have for the system and what we're dealing with. Thank you. Darla?
Hi, everyone, and thank you for inviting me today. I just want to give you kind of a 50,000 foot view of what I do, and hopefully that can help to inform at least the referral and admissions part of our process at DSHS for competency restoration orders. So I don't have a lot of activity involving evaluations or inpatient evaluations, outpatient evaluations, or PR cases. per se, but I can inform a little bit about those if you have questions. So I see that that is an agenda item. And so I do have a little bit of information to provide on those. But what I focus on mainly is competency restoration orders. And so those are inpatient competency restoration cases, people who would be going from not a community setting, but a jail setting into one of our 4 restoration treatment facilities. And those 4 facilities are Eastern State Hospital, Western State Hospital, or 2 of our RTFs, which are Fort Steilacoom Competency Restoration Program and Maple Lane Competency Restoration Program. Fort Steilacoom is located actually on the campus of Western State Hospital, although it's not actually part of Western State Hospital. And Maple Lane is down in near Centralia. I think it's in Grand Mound. I'm not from here originally, so I'm still kind of learning, but it's down near Centralia, Washington. Been there a million times, but I can't tell you in a meeting where it's located. So the process starts when we receive a court order for competency restoration, either a 90-day for a 90-day admission, a felony admission, a 45-day felony admission, or a misdemeanor admission for competency restoration. And so when our office, when I say our office, I mean it's actually segmented. So when a West Side court order is received in the OFFM's email, we have a special email where those court orders go to, or when the East Side receives a court order in their special email box, those orders are processed. And so that means that an administrative personnel looks at those court orders for accuracy, to make sure they're signed, to make sure that the dates are correct, that they have the right kind of information that goes along with the type of legal authority that is listed on the court order. They also make sure that we have supporting information. So they make sure that we have discovery and charging documents and police reports for that charge that's connected with those cause numbers on the court order. They also pull a criminal history report. So on the West Side, it's a watch report. On the East Side, they actually pull the entire NCIC for the whole United States. And then they also run a discovery search internally to locate and apply the most recent evaluation report to this packet of information that they put together. So all of that goes together in a file that I review, and my administrative assistant requests jail screening. So we contact the jail to request the most recent records on this individual so that we can get a presentation for them regarding mental health or physical health and physical health. So we want to know what's going on with them. How are they behaving, or how are they presenting medically in the last 72 hours or so? We have to have that information because that information is put together in not only in these packets, but all of that information is entered into our forensic data system. Our forensic data system is an order tracking system. So the people, the administrative assistants that I mentioned, are putting that information, entering that data into a forensic data system so that our entire office, including all evaluators, all of the people involved in this process, can see what's happening with that order in the chain of events as it goes through the system. So once I review each of those packets, those competency restoration packets that are created either on the West Side or the East Side, depending on where the person is in custody, then I determine where that referral goes to. So based on a set of admission criteria that our office developed in coordination with the courts and the local courts, the federal courts, and the AAGs for the state of Washington, I look at it and decide, can that person meet criteria to be admitted to one of our restoration treatment facilities? Our restoration treatment facilities are kind of a middle level of care, if that makes sense, like an intermediate level of care. So although they're secure, they don't have the level of intensive treatment that might happen at a state hospital. But we also have a lower level of intensity in treatment. And I don't want to dismiss the type of services that people are receiving. But in the outpatient competency restoration program, the person lives in the community, has really strong supportive services. But for a restoration treatment facility, a residential treatment facility where a person receives restoration, it's kind of in between those two. So we have the state hospital, we have the RTFs, and we have outpatient competency restoration services. So if that person meets criteria to go to an RTF, then I make a referral. So based on the type of setup that the RTF has. So we have one RTF that has co-ed services. They're set up to be co-ed. And then the other one is male only. And they each have their own set of criteria aside from our general overarching RTF admission criteria. So I make the referral and I basically send an email and ask Maple Lane, for instance, if they will take a look at this information, share it with their internal providers, and come to a decision on if they think that they can admit this person. Once they make that decision, the person is either A, put on their wait list for admission, and their wait list usually isn't too long, or the person is, or they reach back out to me and request a consult. So if they have concerns about how this person is presenting, and they basically are not in agreement with what I saw in that big packet of information, then they can reach out and say, hey, we don't really feel like this person meets criteria to be admitted to our facility. Or, we found out new information. We called the jail and did a nursing one-to-one, and they told us that, in the last 2 hours, this person was put on lockdown. And so we don't feel like that our milieu is the best place for him or her. So we have a meeting by phone. We either talk by phone or Teams, and we share information and come together to either agree that this person should be admitted to the RTF or the person should not be admitted to the RTF. If the person is determined to not meet criteria for the RTF at that point, the referral is rescinded and the person is added to the wait list for the state hospital. If we decide that the facility can take a chance and maybe things aren't too bad and they can probably treat this person in the RTF, then they move forward and it's considered that the referral stands and the person proceeds with admission, or the facility proceeds with admission for the person. If to step back a little bit, if in reviewing that packet originally, I determined that the person doesn't meet criteria to begin with to ever be referred to the RTF, then they immediately go to the state hospital wait list. I do re-review periodically. If someone, for instance, if they're not taking medication or if they have really high psychiatric acuity, then those are things that are dynamic and not static. And so I may reach back out to the jail in a couple of weeks to say, hey, is John Doe taking his medication yet? How is he presenting now? Has his behavior regulated? Did he have dental surgery or whatever what might have been keeping him from going to the RTF? So that's, in a nutshell, that's my role. I kind of run air traffic control for the wait list and the court orders for competency restoration that come into our program. So I'll be happy to answer any questions.
I saw Mike Parker first and then Chief Tanksley.
Carla, thank you so much for covering that. And it certainly sounds complex. And most of my questions are just double checking to make sure that I really kind of understood what you were sharing with us. And I appreciate that. The first one that you mentioned is that admissions criteria. So you've got a set that you're looking at. Does a person meet criteria for residential treatment facilities? And you listed a couple. That sounds like an alternate path. So not coming to Western State. And that those individuals, would they be getting then competency restoration services at a residential treatment facility? And I think you mentioned Maple Lane is one of them. So that would be one avenue. Did I get that part correct?
Yes, so that would be like the intermediate level of care that I mentioned.
Gotcha. Right. So there's an outpatient, which is they really don't need to be in a facility at all. They can get those services out in the community. You've got your middle ground, and then for the ones that Maple Lane and other facilities do not take, they go into the Western State list. It also sounds like, did I get this right? So you've got your set of criteria. There's another set of criteria. Is there yet a third set of criteria for Western State, or is your criteria that you mentioned the first time around the one and only that is used both to send to an intermediary or to Western State?
That's a really good question. So Western State Hospital or Eastern State Hospital, they're state hospitals. They generally don't have criteria. Western does not have a set of criteria. They're the state hospital. They are required to take patients from the West Side no matter what. And the reason I'm kind of splitting that into only Western State hospitals, because there are times when we make referrals on a pretty regular basis to Eastern State Hospital from the West Side. However, and these aren't strict criteria, but when we see that the East Side, Eastern State Hospital has capacity to admit, and they have beds waiting and beds open, and we need those beds, I have to reach out to the administrator of the forensic services unit at Eastern State Hospital and ask if they can accept a few West Side patients. And so there are some criteria. They don't really feel comfortable taking people who might be at risk of having a 7105 for people who are at risk of being flipped to a civil commitment, because that's a really quick turnaround on the part of the state hospital. They have to have everything set in place within 72 hours. And, so especially in the winter time, sometimes they can't get the person back to the West Side in 72 hours. So that places a hardship on Eastern State Hospital. And possibly some legal issues because of legal authority. And so and testimony from a psychiatrist from the East Side for a West Side patient. And it gets just really, really complex. So they don't like to do that, understandably. And also they have to have agreement from the defense attorney that the defense will either go to Eastern State Hospital if they want to participate, or that they'll be willing to forego participation in any meetings or hearings or treatment, or that they would be willing to meet telephonically or through televideo. So there is kind of a set of criteria. It's not going to stop admission for that person on any count. It just means that person wouldn't be placed into that Eastern State Hospital bed if those criteria weren't met. So yeah, there's a little bit of a thing there, but it's not formalized. It's not in policy, whereas the RTF admission criteria, that is an OFM/DSHS policy. They have to meet those criteria. I'll be happy to share that policy. I can send an email to you all and copy the policy to you.
That would be great. I think that would be helpful for some of our practitioners that go down to that level. Yeah, so it sounds like a challenging world. You're juggling different sets of criteria, and although your primary, you described your role as a traffic controller, I bet there's a little bit of advocating on your part too to try to get people into placement. So it sounds like you wear a couple hats. My last question and follow-up question, just making sure I understood. You did mention that once you get those folks, you kind of log them into a DSHS tracking system. So that person, it's known that they're in there for competency restoration services. There's a need anyways. right? They get tracked. And then eventually, I'm sure once they get placed somewhere in some facility, that gets updated. Is there any way that any of your local courts or courts of limited jurisdiction or people in our county, do they get access to that DSHS tracking system? Are they able to get information about the whereabouts, the timing, what the process looks like? Or is that DSHS tracking system, is that totally internal?
At this time, it's totally internal. I'm not sure what access our own AAGs have, but I do know that they reach out to us for information on status. The AA1 that I mentioned earlier that works for me actually is the person who, we have that person in a position so that part of their job is to answer all of the multiple status requests that come in from either the RAAG's office or from the local courts and defense attorneys, prosecution. So we have a position that answers those status requests. And at this time, our external partners, to my knowledge, don't have access to our system.
Okay. Darla, thank you so much for all of your answers. Appreciate it.
Thank you, Mike, and thank you, Darla. I saw Chief Tanksley's hand up earlier. Did you have a question, Chief?
Sure. So in 2017, there was an analysis conducted on the programs, and the report is fairly extensive, about 45 pages. Is that report still accurate, or has it been updated?
I'm sorry, can you tell me what the analysis was called? And I might be more familiar. I'm not placing it. Are you talking about maybe the groundswell report? Okay, good. We have actually recently had some discussion about getting with groundswell and maybe updating that. That report was actually started, I think, in 2016. I want to think maybe even earlier. You know what? I came to DSHS in 2016 and that report was already available. So I think I don't have it in front of me, but I think it's 2015, honestly. So they did do a little bit of an update whenever we started to build strategy for the outpatient competency restoration program as part of our True Blood settlement agreement. And that may be what you're referring to. It wasn't a full update of that entire report, but they did update some of the numbers regarding counties that might be involved in outpatient competency restoration. It is available online. I think that you can actually go to our DSHS website and see a copy of it. Otherwise, I can also send that out with the RTF policy. But again, it's 2016. It's very comprehensive. It provides a great deal of background for our services. We still rely on it pretty much, just knowing that internally we know that we have different numbers now.
Thank you.
Mm-hmm. Thank you, Chief Tanksley. Jackie?
Yeah, thank you for this information. It's great information. I appreciate it. I was wondering, after True Blood was passed, it seemed like folks were getting better access to evaluations, but it looks like the bed issue is still problematic. For example, at the jail here, we have 6 people waiting who have been evaluated, but need to be restored to competency. And I'm just wondering, and you may not know this at your level, I don't know, but what is the state doing to improve access to actual competency beds when they're needed at Western State?
Thank you for that question. So overall, we've been, our focus is to improve continuously on those, on that capacity to be able to treat competency restoration cases. However, just like every other facility in the world, we had some setbacks because of COVID. It seemed like there for a little while, especially in 2020, if our state hospital wasn't completely shut down for admissions, then one of our RTFs, if one of our RTFs wasn't, then they both were, and it got pretty complicated. And I think at one point all admissions were stopped for a week or so, just whenever at the height of the pandemic. So yeah, with that in consideration, we're moving ahead. Right now, we are not at full capacity with our state hospitals. Eastern State Hospital is using one of their admission wards for a pre-admission quarantine ward. So whereas they at one point had 2 admission wards, they only have 1. Western State Hospital changes pretty rapidly on their capacity because it seems like once they get to the point where they can open up to full capacity for admissions, then they have a positive case and they have to shut down 1 or 2 wards. So that's kind of changeable on a regular basis, unfortunately. Fort Steilacoom recently had admission holds because of a positive COVID case. They're starting this week, though, to accept admissions, or I think the coming week to accept admissions again, and Susan can probably speak more to that. Maple Lane, they did shut down for a little while in 2020. They haven't shut down recently from my recollection. So not to make excuses, but we've been operating on kind of a deficit in beds for the last, since the pandemic began. But our whole focus is on making more beds, having the ability to admit people in a more timely way, in a more efficient way. That's also why we have one of our programs is our triage for expedited admission. So if people are waiting too long in the jail and their mental health or medical health is starting to decline, then there is an outlet. There is a way that the jail can, or the attorneys can request expedited admission into the state hospital. So we have that in place as one strategy.
Okay, so just to sort of summarize, you're saying that absent COVID, that the state thinks there would be enough beds for competency restoration, then it sounds like. And then the other thing is, so how does one get access to that alternative route you were mentioning?
I'll be happy to send that out too. We have a guide. It's actually just recently, and I think it was like a year ago, been updated. So we have a really nice guide for attorneys and for jail staff, because it's a little bit of a different process for each. And we also have a form that goes along with it. I'll send that out. And just to address your comment, we're working on establishing more beds. So Eastern State Hospital is going to be opening more beds. Western State Hospital is going to be opening more beds, but it's just that, COVID caused a few setbacks.
So I'm actually going to chime in. Hopefully you can hear me. My name is Tom Kinlan. I'm the director of the Office of Forensic Mental Health Services, in which Darla works in. Apologize. I think there was a little name issue that it looked like I was Susan Copeland. So I apologize on that. So I was a little bit of an interloper as Susan before I realized, wait, my name's not showing up. And so these are great questions. I just wanted to add a little bit more on the bed capacity issue. So Darla is spot on that COVID really did, not only for probably everybody on this call, and then some, but with the state hospitals as well. And so we were planning to actually add additional capacity beyond, say, limiting space because of social contact, needing that 6 feet, not having 2 people in a room, so on and so forth. So as we continue to hopefully get a handle on the various variants, not have positive cases, we can open up some beds that are already existing at Western State Hospital to treat for competency services. In addition to that, we do have 50 beds that are being built as I talk to you right now. That's going to be on the grounds of Western State Hospital, with the opening, I believe about a year from now is what we're targeting for Western State Hospital. So that's an additional 50 or so beds that are being actually constructed. In addition, I'm sure you guys have heard about the settlement, contempt settlement agreement, where we are looking at 10, soon to be 11 counties. King comes online in March of 2022. And a lot of that is targeted upstream to divert, deflect, get individuals out of the competency system and hopefully receiving services appropriately outside of that system. So we really focused on some of our highest referral counties: King, Pierce, Spokane, Clark. Those tend to be, they're 4 out of the top 6 highest referring counties in the entire state. So we're hoping with that diversion and deflection, we have less of demand or less referrals, but we are actually looking at expanding capacity with a third project that we're looking at creating an additional 25 beds by moving some NGRI patients to a new kind of off-campus facility as well. And that's a late 23, early 24 project. So that would create an additional 25 beds at Western State Hospital. So we are continuing to add beds. I believe Jackie asked, does that mean that that is all the beds we will need? The answer is probably not. If we continue to get referrals at the rate that we do, that we would need to continue to expand and create even more beds in the system. Now, that's why we're hopeful that we have success with these counties that are already using some of the diversion and deflection strategies that we developed, that we can sort of decrease that demand on referrals so that we hopefully can get closer and closer with the bed count. So you heard some of that from Darla with using outpatient restoration as one of those tools where they wouldn't have to go in the facility. And we do have the 2 residential treatment facilities. When outside of COVID, they do have 60 beds between the 2 of them, so 30 beds apiece. So I just wanted to jump in there because I apologize on sort of being misnamed there for a bit.
And I just had a follow-up question, Tom. I wondered, how's it going with hiring staff given the workforce issues going on in the field?
Great question. And much like everywhere, probably in your local area, the entire nation, yes, struggles with, well, we've always had struggles with psychiatrists at the state facilities. Nursing, now we're starting to see an impact with nursing and some of our level clinicians and so on. So it is a bit of a struggle, yes. For us as well to hire across the board. And I know we're trying to look at what are some different recruitment strategies, recruitment pools or ponds or oceans that we can try to tap. But, you know, this pandemic has really changed the workforce in the last 2 years than what we were dealing with previously.
Thank you, Tom. It looks like I have Arlene and then Dan Hamill with questions. Arlene, can you unmute yourself and
I'm wondering how many years you think it will take to implement the governor's plan for regional hospitals, or is that still going to happen?
So this is Tom, as we're looking at kind of regional facilities. I know that there is work ongoing that we're involved with, a 16-bed facility in the Centralia, Rochester area, another 16-bed facility in the Vancouver area that we would manage, we being DSHS. Another 32 beds in that Vancouver area would be managed by the Healthcare Authority. So those are the ones I know specifically, Arlene, and those are about 2023. I think one is summer 23 and the other is fall, and I don't know which one is which, but that would be some additional capacity for individuals in the community. But outside of that, I don't know the touch or reach of the actual governor's plan for other facilities and how that is progressing. I will say,
I think he was talking about something entirely different. It sounded like he was going to be building new facilities in 4 areas.
So the only other facility that I know of is the teaching hospital at the University of Washington. But I apologize. I don't know of any of the other 4 facilities that he might have referenced.
Okay, thank you.
Thank you, Arlene. Dan?
Thanks, Tom, for the information. I was just curious if you could touch on those upstream diversion and interventions that you had spoken about earlier in your remarks.
Sure. So the big areas that we're focusing on for the contempt settlement agreement and some programs outside of even the contempt settlement agreement focus on residential supports. What can we do in the housing area? So what can we do with individuals, whether it's vouchers? Are there things that we can do brick and mortar? What can be done to get people stably housed? So that's a huge factor. There's also co-responder programs. So pairing up law enforcement with behavioral health providers so that they could respond to calls and have a behavioral health professional with them, and hopefully then be able to divert the individual from being booked or arrested to hopefully one of those facilities. In some of these areas, it's actually increasing crisis stabilization capacity. So in Spokane, a 16-bed facility was built. King County, 2 16-bed facilities are going to be built for crisis stabilization. We also work on I would call it, this is me being very simplistic, so I apologize, but probably the easiest way to conceptualize it is intensive case management, really reaching out to those individuals that have had repeated engagements with the criminal justice system, and how to reach out and engage them and wrap them into services so that they can get out of that system, not be arrested, and then go through the competency system and hopefully receive the services they need to be supported in the community, to looking at crisis intervention training for law enforcement. So making sure that they are able to attend that training that's being offered, whether it's the 8-hour course or the 40-hour course. Outpatient competency restoration, so possibly individuals that didn't get diverted upstream, instead of going to an inpatient facility, receiving competency treatment out in the community. So we have that program as well, which is tied to forensic navigators. You might have heard of them. Forensic navigators get involved when somebody does get a competency evaluation, and even before, to try to divert, offering ideas, suggestions to prosecution, defense, judges. Hey, Tom stole some gum. Do we really need to go to the competency route? Is there a different program, a different opportunity, different services that we can engage them in? If not, if they're like, nope, Tom is going to go through the competency system, okay, can we do it outpatient? Can we not have to send them to Western or Eastern State Hospital or one of the residential treatment facilities? We're also looking at workforce development. So the question that someone asked about being impacted, and yes, so we're gathering information and seeing what can be done to strategies that we could introduce to try to help, and not just DSHS, but other entities as well, to see what we can do on the workforce end of things. So that's just a sampling. We're kind of, if you're familiar with the sequential intercept model, we're trying to address from 0 through 5, in all honesty, with the sprinkling of these different programs.
Hey, Raylene, can I just follow up real quick?
Yes, please.
So, Tom, it's as if you just read the playbook for Whatcom County. We do a lot of those things. We have the sequential intercept model. It's how our incarceration prevention and reduction task force models its programs and policies and recommendations. We have a what's called a GRACE program, ground level response and community, or ground level response and engagement. What does the C stand for? I was one of the founders of that program. Anyway, we work with frequent flyers, people who are in touch with the system quite a bit. We have the LEAD program, the law enforcement assisted diversion program. I see that Doug Chadwick is on the call, Under Sheriff Chadwick. He's starting a co-responder model in the county. Bellingham is looking at a alternate response team that would provide a behavioral health specialist along with an EMTB for certain types of behavioral health calls. We have a crisis stabilization center, 16 beds on one side for mental health and 16 on the other for substance use disorder. We have a home fund here. I was one of the 3 architects of that in 2012. That raises, now it's $4 million a year. We just passed $1590, which is an additional $3 million in the city and $2 million in the county for housing. We have a lot of the major food groups that you just discussed, yet we're still facing the same problems, and perhaps they're in a smaller capacity than in other similar jurisdictions. But I just wanted to let you know that we're working on those things, and I think we see the solutions perhaps in the same way that you may, but we're still kind of treading water to some degree. And so I want to put that out there to you and the group.
Yeah, I really appreciate that. This is Tom again. That's one of the things we're doing is also obviously a big data analysis of what is working, lack of better terminology or not. And again, in these areas, some of what we're seeing initially is, well, we might not be stemming the referral process for competency, but we're seeing better or more positive outcomes for those that do go through it. In other words, okay, so you did go through competency, but you then had lower rates of recidivism, more engagement with outpatient treatment. So that is one of the things, Dan, I think that was you that was talking, that yes, we're definitely looking at that, because I think one of the things is, it seems like we have the ingredients, much like you, but perhaps we're not combining them in the right combination to get what we're wanting to get at. And of course, one of the areas that we're looking at and that we're going to be doing with our 10 counties that we're working with now is, so are we missing something? Is it something that, we're even like, do there need to be some statutory changes? One area that we look at is just misdemeanors. We do so many evaluations for misdemeanors. And then obviously, what does that look like for restoration? It's kind of a interesting subject, because it's not that you can keep them very long in restoration, and sort of what is the end goal with somebody that has, say, a low-level misdemeanor and trying to go through the competency system. So I think you're spot on with, okay, we're doing all of this, but yet some of the numbers or all of the numbers just don't seem to be touching perhaps that referral. And of course, now we've got an artifact with COVID, and I don't know how it is in your area, but I would assume it's similar. Now we're also getting kind of backlogs of cases. And how is that now impacting what we're seeing? In other words, if we didn't have COVID, would we have been seeing maybe bigger gains? But now it seems like, well, gosh, our referrals have not gone down, they've even gone up. Well, is that because we have to address 50 more cases a month out of Whatcom County because of cases that weren't addressed during the pandemic? So definitely some of the things that we're looking at from a data perspective as well. So great comments. Really appreciate that.
Thank you, Tom. I see Attorney Smith and then Mike Parker.
And good afternoon, everybody. Jason Smith. I'm the owner of North County Public Defense. We represent people charged with misdemeanor, gross misdemeanor crimes in all the cities of Whatcom County except Ferndale. I had a quick question on contact information for either case managers, directors, or even clinicians at Western State. I think it'd be a great idea to have myself or my attorneys be able to have a little more open dialogue and contact with people like that, so we can get more updated information about our clients when they're undergoing restoration. And I have a second question. I need to be getting to an in custody hearing in a moment, but I was curious as to whether or not DSHS had any plans or thoughts on outpatient mental health services or prescription monitoring for people who go through the process or are diverted from the process of competency, and how can we monitor people who need mental health treatment, who need prescription services, and who need those sorts of things, but don't necessarily have access to them when they're just released from custody.
Thank you, Jason. This is Tom. We do have a resource list, I think, with that contact information that would be helpful. So I will get that out to, I don't know, Raylene, is that best to get to you or to distribute, or what would be the easiest way to get that out to folks?
If you could actually send it to Jill Nixon, she can route it to the appropriate individuals. Thank you.
I most certainly will. Thank you for that. So Jill is be looking for that. And then for the second question, I don't know of other than discussions. I know that's something that we're working on with the competency process when there are forensic navigators to really implement and put into practice the theory of warm handoffs and have those connections. So that's what I'm able to talk about that I'm aware of. So the 10 counties, soon to be 11. I don't know of discussion beyond that per se, at least at my level. There definitely could be going on, but mine is kind of focused on what we might be doing in the forensic and the contempt settlement agreement and so on. Outside of that, I don't know of anything as of today that says, okay, what is DSHS necessarily going to be doing as it relates to, say, Whatcom County, as somebody that's leaving jail and monitoring services at this point. I don't have any information on that today.
Thank you, Tom. Mike?
Yeah, Raylene, I'm not sure who was going to bring up Chief Jones's question. So our chief of the jail, unfortunately, Tom and Darla, wasn't able to make it to our meeting today, but this is a big subject for us. So we will be having multiple meetings about this. But one of their observations was, between 12 and 15 folks currently waiting in Whatcom County Jail. I believe the first one was a start date of around September. Darla, I think you've kind of alluded and kind of addressed this to some degree, but obviously we have this backlog. My particular point in bringing up one Chief Jones question is one I have the question too. But Tom, I was really interested as you were talking about forensic navigators and really seeking to do some of it outpatient, if you will, when trying to obviously do some diversion, and that sounds more what the forensic navigators were doing. But is there opportunities for any of that outpatient work to be done? Which would help address your backlog, but maybe with people that are currently incarcerated? Or is the only pathway for that person once they're in jail awaiting competency restoration is being seen on an outpatient basis not even possible? And I guess I'm thinking of that to try to address that backlog. And obviously our concern in our community is when folks are in jail and they really need treatment, they're not getting better, they tend to kind of get worse. That's at least a concern from myself as a social worker. I get concerned about those long wait times, not just frustrated, just don't want them to get any worse before they can get some assistance. So can you maybe speak to, I guess, your forensic navigation? Can they do outpatient restoration services in any way, or is it all diversion?
Great question. And yes, much like you, we share that same concern that we have so many people in need, but unfortunately can't get them to where they want to be because, for example, we don't have enough beds. To answer your question, so yes, in those 10, soon to be 11 counties that have outpatient competency restoration and forensic navigators. So DSHS manages the forensic navigators. Healthcare Authority manages the outpatient competency restoration program. And the short answer, Mike, is yes. If you have that, what happens is that navigator gets involved with Tom because he was arrested and we're thinking maybe going the competency route. So the navigator is going to say, okay, can we try to divert? Is there anything? Nope, we're going to continue to go that path. So then the navigator shifts gears a little bit and starts saying, okay, but I think we can treat them in the community. And so then working with Healthcare Authority, who has contracted providers, then if the judge signs off on that, then yes, we treat those individuals in the community. And as you're getting at, another way to try to save those valuable beds then, because now that person's being treated in the community, didn't get put on any wait list and won't take that bed because they'll receive the services in the community. So yeah, that is a huge impetus behind that whole outpatient program is for low-level felonies, though there is no exclusionary criteria, but we also understand public safety risk, things that prosecutors, defense, judges are all going to take under consideration. So you probably are looking generally at those misdemeanors and low-level felonies as probably that category of individuals that would be the best fit for outpatient restoration. And yes, we would like to see that expand, grow, be used. And so then those individuals would not be waiting for a bed. And then those that are, say, the most acute of the acute would be able to get into those inpatient beds much sooner than it, what's occurring today. So yes, that is the hope, that is the plan.
And just a quick follow-up, we are not one of the 11 counties, is that correct?
Yeah, so great question on that one. So for the contempt settlement agreement, it's rolling out in phases. So phase 1 was the Spokane region, Southwest region, and Pierce region. Phase 2 is King, and phase 3 is a sort of to be determined. What does that look like? What does that look like as we roll things out? Do we need to work on phase 1 and 2? Kind of getting to that question that maybe Dan said, hey, you guys got all this in place, but you haven't moved the needle. Do we need to maybe go back a little bit to that, cooking board, if you will, and remix the ingredients to try to get the right combination? Or are we going to expand into other regions? And just to let you know, we would do sort of region expansion. So if you guys are North Sound, is that right?
That's right.
So that would be the region. So I think that includes you guys in addition to Snohomish, I think, and some of the other counties up there. So that's how we would look at. So it wouldn't be a county rollout. It would be more of that region, BHASO type rollout that we would look at. So it would be, if you guys were selected as the next area, the 5-6 counties that you guys are part of as part of that region. So there will be more to come on that. We also have to talk to the plaintiffs. We have to talk to the judge on seeing what next steps we would do as part of phase 3. But the ultimate goal for a lot of these is to eventually, if the programs are showing success, to replicate those programs, not just in King County, but all 39 counties.
Yeah, it certainly sounds some benefits, and I can see it blending as Dan gave you a highlight of some of the diversion facilities and activities and programs we have going up. It would fit very well with that. So we're a collaborative bunch. We would love to jump on board with that. We like to be early adopters up here, so we would certainly do that. Darla, I wondered, you gave a really good conversation, and because in that general about forensic was also kind of a specific, hey, we've got 12 to 15, and I just wondered if you had a comment for us or for Chief Jones who couldn't be here today about those folks that are currently waiting in the Whatcom County Jail. I see you talking, but I can't hear anything. Maybe it's just my speakers.
Oh, it was me. Sorry. I'm double muted. So I clicked and I didn't click well enough. Sorry.
No problem. No problem.
So honestly, without pulling open the forensic data system and just kind of doing a quick analysis and looking, I can't really give you a lot of information about when those people would be admitted. Some of that also depends on when we get the screening from the jail that we request in order to make those reviews. And so I without opening it and doing a little analysis, I can't really tell you. I hope that those people meet criteria to go to an RTF and we can get them admitted as soon as possible. I know that if they're going to Western State Hospital, there is a little bit of a wait right now because, like I said earlier, the capacity for admissions is down because of COVID. So I can't really give you any really detailed answer on that. I'm sorry.
Oh, that's all right. Thank you.
Sure.
Thank you. Jackie?
Tom, it'd be great to see what the outcome measures expected for the community program is, as well as, I know it's early, so you probably don't have any real outcomes yet, but to see how those are developing as well.
Yeah, most definitely. And our plan is, I believe, March of 2022 is when we're expecting our kind of first big data report. So I'm not sure who the best person to, whether you want to use Susan or Darla or myself. But if you can stay in contact with us, once that's completed, we'll definitely be getting that out to individuals and want to make sure that we get that to you guys as well, so you guys can see what the data is showing. So right now scheduled for March of 2022.
Tom, thank you for that. We would appreciate any data and continued assistance with this issue. I don't think it's going to resolve itself in one meeting. Obviously, there's a lot involved. I do have a couple questions. One issue that I see with the misdemeanors is, and I don't know if you'll be able to answer this or direct us to who can, because first we got to get competency evaluations done, and it seems to be a quicker process for the eval when somebody's booked, but we have a lot of misdemeanors that are transient, that don't have a lot of support, that need that competency eval, and then we're waiting on it in our court, and then they go ahead and go to a different jurisdiction and find themselves in trouble somewhere else. And so they're racking up charges while we're waiting for an evaluation or restoration. And we're struggling with getting them the assistance, because who's going to get them there if they don't have the family or support? I don't think we can really rely on the defense counsel to be transporting some of these individuals for these evaluations. Do you have any thoughts or programs that might assist for those that are out of custody?
Yeah, that's a great question. So out of custody, we'll call them, our terminology would be personal recognizance. And we do have evaluators that complete that work. Unfortunately, much like in custody, there's a lot of those individuals as well. So I know we're trying to look at different strategies from, would it be helpful to have an evaluator in a certain location one day? I'm just gonna make this up, like one day a month. And so like 4 people could go to defense attorney X's office to get the evaluations completed. So I do have a contact that I'll provide that to Jill as well, that you can use. So we do have a supervisor for our out of custody evaluation team, and he could talk more with you, Raylene, or whoever else is interested in this, about kind of what he's doing, what his team's doing, and what needs you might have that they can address. So I can provide that contact information to Jill.
Thank you, Tom Kenlin. Attorney Lydon, do you have any more input on that? What you think would work for you?
At this point, I really don't. I'm kind of trying to synthesize all this information. I think, getting some more contact information. I generally only have contact with individual evaluators on a case-by-case basis, so I'm looking forward to that.
Thank you. Is there any other questions for Tom or Darla? I don't see any other hands up. I really appreciate you guys participating in this meeting, and would look forward to you guys assisting us in other meetings and data as moving forward. You're more than welcome to stay for the remainder of the meeting. We do want to discuss reentry services and vacant behavioral health specialists with navigation. And I think those kind of link into some of what you do. So feel free to continue to join us on today's meeting. If you have any other questions, you can chime in.
Thank you so much. This is Tom. Unfortunately, I'm double booked, so I have to jump off, but would love, future invites. I apologize, not on camera, because I'm like actually in a kitchen in a conference center because of where I'm at. So my apologies, but yes, if there are other things that we can help provide information, whatever it might be, we're definitely here to assist and would love to do that. So thank you again for allowing me to sort of party crash a little bit and be able to answer some of your questions. And thank you.
I'll stick around if you don't mind. And thank you, Dr. Kinlan. This is Darla.
Thank you, Darla. Dan, do you want to lead us into the next session?
Sure. And apologies, I have no idea why I'm up on the screen twice. If I could only do this in real life, I would get so much more done. Anyway, I won't go into it. By the way, the C and Grace is for coordinated. Sorry, we had a 14-hour city council meeting yesterday. We didn't start general business until 10 o'clock last night, so my brain's pretty fried. But I will introduce the next speaker. So the next item on the agenda is vacant behavioral health specialist position in the jail, and here to take us through that is Jackie Mitchell.
Sorry, did you say I'm the next speaker?
Yeah, we shifted the agenda around to accommodate our guest speakers.
Oh, okay.
We're gonna bring it back in order now.
And what am I speaking about? Reentry or?
Yeah, so we've got you on vacant behavioral health specialist position in the jail.
Oh, okay, great. Yeah, so I think I mentioned well, actually I mentioned this in the Legal and Justice Committee that we had not too long ago, that our current contractor, which is Compass Health for the jail behavioral health program, signified that they wanted to terminate the contract early due to inability to hire staff. And so we put out a request for qualifications, and we had 2 applicants, and one of which seemed pretty well suited, and that was Lifeline Connection. So we hurried up and hired them to get somebody in there for the last 2 months. And basically what they're doing is sending their regional director in to survey the needs in terms of the inmates in the jail for behavioral health, and try to determine what and what kinds of jobs her people will be doing. So the next step, she's investigating the crisis response services in the jail, and the next step is to investigate the reentry portion of the program, and with the plan to hire a clinician by or soon after January 1st. So we were unable to, in our negotiations, to hire or have hired a peer person on this particular program because we needed all the funding in our budget to hire the clinical staff. And Lifeline does a pretty good job of trying to attract folks to their organization. So I have a lot of faith that they'll be able to do it. Yeah, any questions so far about that?
Questions for Jackie? Arlene, you're on mute.
This is just one position?
Correct. Yeah, we were hoping for a peer to be in this program as well. Julie does, however, say that, but like I said, we could only afford really within the budget to hire a clinician, so, and still be able to pay well, because it's a really competitive environment out there. But Julie does have, well, she runs some of the community outreach programs because she's the community outreach director, community services director, I guess is what they call her, regional director. And so she runs the PACT program and the peer Pathfinder program and a couple others. And those programs actually have staff that can go in and send peers in to meet with people and have done so already. So we're going to continue that and kind of look for some other funding to increase our reentry component of this particular program.
I guess I'm not quite understanding what you're saying. It sounds like it's not going to start until the 1st of January, or people have already been going in and providing services.
Well, I guess both of those are actually true. There have been peers and are peers that go in now on other programs. So I sent an inventory of reentry services to the committees, and on that inventory lists some programs that will do reentry work with people in the jail, including warm handoffs. And then the other piece of what you said is also true, which is for this particular program, we'll be hiring the case manager probably around January 1st.
And so how many people are to be served by the case manager?
Well, that's a really good question, Arlene. In the past, when we've had a full-time person in there, we've served probably around 300 or so in a year. I don't know. I think we need to talk about what the caseload should look like between the contractor and myself, so that we can really well define the caseload and make sure we're touching the people most in need and most vulnerable coming out into the community.
So I think that's one of the statistics we've been trying to get a handle on over the last 6 months or so, and that's about how many people are in the jail, even on average. Does anybody have a statistic on that?
Yeah, we can send out some information. I can send out some information. I had to round this information up to put it out for some of the questioners who wanted to, some of the folks, agencies that were considering applying for the RFQ. So we have some things like average daily population, number of bookings, number of releases, number of people served by the jail behavioral health program, that kind of thing. So I can send out a little table for sure.
Okay, because that is, we're talking about proportion of staff to people to be served. It's a vital statistic, and it will determine the effectiveness of what we're doing or trying to do here.
Yeah, I agree. I think it's useful information for sure in determining that.
Thank you, Arlene. Jackie, I have a question for you on this Whatcom County Jail Behavioral Health Reentry Services. On the back page, I've got reentry services not specifically related to behavioral health. And one of the items you have is a homeless outreach team by the Opportunity Council. Can you expand on that? Is that something where they go in, or does somebody have to request that? Is it like defense counsel says, hey, I've got a defendant that doesn't have a place to go when they get out, and we don't want them to have behavioral health or drug issues when they get out. We want that outreach. They might not have that behavioral health factor, but they could if we don't go to them and assist them once they get out. Is that where that is, and how does that work?
So, this used to be Mike's program, so he probably has a better grasp. And Mike, correct me if I'm wrong, but they get both referrals from staff in the jail and from folks outside to go into the jail. And then what they usually do, the HOT team does, is some sort of screening. It's called a SPDAT, but a screening to determine the person's level of sort of risk and need, vulnerability in regard to homelessness. And the nice thing about this team, I would say, they're not behavioral health specialists on the team, but the good thing about them is that they're very well connected with a lot of the teams that provide behavioral health services. So some of Julie's teams like PACT and Peer Pathfinder, and then CORES, which is Community Outreach and Recovery Services, whom I've also seen at the jail, and a number of other programs. So they know when something requires a behavioral health response, that they don't have the staff to do that, and they can make that referral as well. Mike, did you want to add anything? Because you're more
I'll go ahead and chime in, Jackie. That was a great coverage, by the way, and yes, that was my former team, so I know a little bit about them. And so for folks in city of Bellingham, it's pretty easy, and that's, you can always call the HOT team. That one of the challenges we have, Raylene, and others, is going countywide. So some of the funding that the street outreach team gets is for folks in the city of Bellingham, and we can see folks outside of the city of Bellingham. Veterans, for example, we do have some veterans funding in that team, and allows us to see a veteran in other locations other than just Bellingham. And then also folks with an opioid use disorder, right? So some of them contract that we actually have with Jackie and the health department adds some of that knowledge, that skill, but also the flexibility Raylene to be able to go to different places in the county. I just want to address that because I know you're largely in Blaine. So calling a street outreach team for somebody in Blaine may be kind of difficult. But if you've got somebody in City of Bellingham, we would be a great call. And as Jackie mentioned, the street outreach team may not have behavioral health clinicians. They're very familiar with the population. They'll probably know your person if they've been in the community for a while, and they can help get that person to some of those more robust or more clinical treatment options. So hopefully my coverage was talked a little bit about how they can be seen out in the county, but it really is more Bellingham focused, although not exclusively so. And I'm happy to entertain other questions if that's helpful.
Yeah, thank you, Mike. I really appreciate that. And we've made efforts and continue to try to make efforts to expand the team so that they can go out into the county. In fact, I thought maybe they had received some other funding recently that made it possible, but I'll check and find out and get back to you if there's a larger response outside of Bellingham that they can make.
Okay, other questions for Jackie? Okay, seeing none, I'm going to move us along here. It's 12:43, and we still have some more items left here. Next item is current use data on the Crisis Stabilization Center, and here to take us through is Perry Mowry. And thanks, Jackie, that was good. And Mike.
Good afternoon, folks. Perry Mowry, Human Services Supervisor with the Health Department. I wanted to share some information just in regards to what we have put together relative to data collection for the Crisis Stabilization Center through the help of there is an advisory committee that we're working with in addition to, obviously discussions with the Behavioral Health Task Force. So what we historically had was essentially a hard copy sheet that there was a number of pieces of data that was being collected. And we actually shifted that into an Excel workbook that collects a significant amount of data relative to referrals from a number of entities, and I'll share that. And then really takes a look at the tracking of those referrals in terms of outcome. So that's what we put together. And now with the workbooks that we've just recently completed through the support of actually Jeremy Morton that works with the EMS and fire. And so now as we are able to collect data, it compiles the data for us. It gives us, year-to-date totals. It adds in and also graphs the information. So I think that that's going to be really helpful just in terms of utilizing data to make decisions. In terms of the data that we are collecting in regards to the reference, the reference that we are looking at, that is the referral sources that we're looking at are law enforcement, emergency medical services, GRACE, LEAD, MCOT, Peace Health transfers, jail transfers, all other professionals, self-referred individuals, and base camp. So we're looking specifically at those referral entities by number, how many were received on a monthly basis. And then, as I said, it rolls it up and will also speak to year-to-date information. As far as the components, there's quite a list of them that we are tracking as far as the referral comes in, what might occur as an outcome of that referral. It starts off with the individual being declined because the beds are at capacity, the individual being declined because of medical reasons and need for a higher level of care, the client withdrawing from services, or possibly even the referent withdrawing the individual because they went someplace else, the individual requiring a higher level of clinical care, the individual being a sex offender, the individual actually completing the recommended clinical stay, the individual being detained, involuntary treatment admission process occurred, and then the individual being discharged due to program rule violation, or that the person remains in treatment services. So that is, in essence, the x-axis of our data gathering that then carries across the referrals received and the number of referrals received. I did compile some information. We opened the Crisis Stabilization Center in January and actually began to collect some data and build some of the data that we were requesting from the providers in May. And so I have some data that's been collected between May and November at this point, and can speak to that if we want to go into that kind of detail, but wanted to stop here. There may be a more general discussion in terms of data collection and so forth that we want to go into.
Committee, questions? Okay, seeing none, Perry, just want to keep going.
Sure. The other thing that I want to mention is we are also, as of 2022, going into a process of where some folks will recall that the original discussion and design of the Crisis Stabilization Center was to also have licensure on the mental health stabilization side, the 16 units that Compass Health is providing services to at the Crisis Stabilization Center. That is for an involuntary licensure. Now, this is specific not to what we commonly discuss in terms of involuntary treatment admissions in the civil law, but in terms of criminal law, that being a 12-hour hold, a 12-hour law enforcement hold. And that is outlined in RCW 1031-110. If folks are interested, I can send that RCW out. And so we are just now launching into that in terms of Compass Health has created a subgroup that is pursuing that licensure at this point, and in hopes of obtaining that fairly quickly and then streamlining the process for that admission process by law enforcement as we move into 2022. Right now, what I have in terms of reference, and maybe for the sake of time, I'll just total this. There was 1,446 referrals made to the detox portion of our Crisis Stabilization Center between May and throughout November of this year. And the bulk of those came from Peace Health transfers. And also were self-referrals. There were limited law enforcement referrals that occurred. And so the two largest entities referring were, again, Peace Health transfers and Self and Family. Now that I just wanted to mention that we sort of pondered this a bit, and the Peace Health transfers were very possibly EMS, originally EMS, transports to the hospital, because at this point in time, the EMS does not have the alternative to go directly to the Crisis Stabilization Center. I won't go into the details of that, but that's not a designated location that they can currently transport to. And so that's probably why that number of Peace Health transfers is, at the level that it is. Again, that was for Compass Health, for the mental health stabilization side. In terms of, I'm sorry, that was for Pioneer Human Services, the detox section. In terms of referrals for Compass Health for mental health stabilization, there was a total of 650. Again, the two top referent sources were Peace Health transfers at a total of 251. And the Self and Family referrals was 292, with actually referrals from MCOT being a total of 44 during this year, and other professionals being a total of 24. We did have 27 law enforcement referrals to the Compass Health mental health stabilization side between May and November of this year. So again, I'll stop there, Dan.
Thanks, Perry. I see Sheriff Elfko's hand is raised.
Yeah, just a quick, thank you for the report, Perry. Just a quick question. Are they going to reserve any of the beds at the Crisis Stabilization Center for the law enforcement 12-hour referrals, or will it just be first come, first served type situation?
It's a great question, Sheriff Elfo, and it actually has come up in our Crisis Stabilization Center discussion, and we have some work groups that are around that as well. The funding for the providers actually comes through at this point in time predominantly a fee-for-service basis, if you will. They bill that to Medicaid, and so their funding literally does not come from the county, but from the managed care organizations, and to a certain extent the ASO that also has some funding. And so when this discussion came up, one of the things that we believe is really important is that law enforcement and other first responders need to be able to contact the facility and determine if a bed is available, because otherwise there wouldn't be a point, obviously, if we're so successful that we are at maximum capacity in the facility, then it wouldn't make sense, obviously, for those professionals to come out to the facility. So we wanted to make sure that ability for the Crisis Stabilization Center to provide that information was in place at this point. And then really, we hadn't come to a conclusion in terms of determining it, because it's really, I think, going to be more based on the utilization of that service to make that determination. Because, of course, on the flip side, if not a lot of utilization was occurring and a bed was remained available and open just in case, then it would create a number of dynamics that we may not want to pursue. So ultimately, that this discussion it's a top discussion as we proceed into 2022, and wanting to make sure that we're admitting priority individuals, which is law enforcement referrals and first responders. So I know I skirted the question just a little bit. I didn't want to offer an answer that I don't have, but that is a topic of discussion at this point.
And that was, from my understanding and my memory, that's what it was envisioned for, was an alternative to the jail to get people into treatment, as opposed to putting them into jail. So I hope that remains a priority. And one of the reasons you may not see some voluntaries coming in from law enforcement is concerns about the ability to transport them. I know there's a reluctance among some of the officers to take people into custody for the concern that they express a desire to get out of the car at an unsafe place, and puts the officer in a difficult position as a result of the legislation that was enacted earlier this year. So thank you very much.
Yes, absolutely. I'm sure that you're aware of as well that we've been looking at some of the language that has come out. I think it originated in November in terms of the behavioral health clarifications discussion to House Bill 1310, with the possibility of those transports relative to individuals that are ITA kind of thing, but understood that law enforcement has some real challenges in terms of being able to effectively support that process.
Thanks, Perry.
Okay, Mike Parker.
Perry, I appreciate your report, and every time you speak on this, I do learn a little bit more, and some of the facts and figures stick in. I have to admit, I got lost a little bit, and I just wanted to verify that I understood. So I think the first figures you gave us were over 1,200 referrals to the Pioneer Human Services side. So that would be to the substance use disorder side of the house. What person, and I didn't get the total number on the Compass, but I guess are those referrals accepted, or those referrals made, and is there a different number accepted? And if so, I think one thing that I know that I'm curious about as a committee member, because I've heard a little bit that there were some challenges to some degree about getting appropriate referrals and having those being accepted. Could you speak to the difference between referrals made and referrals accepted on each side of the house, and any additional comment you'd like to make about that it's improved from what it was, or anything like that? It would be welcome as well.
Sure. A great question, Mike. And yes, I was throwing a lot of stuff out there and made a misstatement here, during that. So to be clear, Detox side, Pioneer Human Services is a provider. They actually received a total number of 1,446 referrals between May and November 2021. Outcome is a little more challenging because a variety of things can happen, in terms of that referral. That is, for example, individuals were referred and they were at capacity at that point in time, and so they declined admission, and so it kind of goes across that that x-axis and breaks down the outcome of that particular referral. And I don't have totals there, but what I can say is that for Pioneer Human Services, they had a total number of program bed dates between May and the end of November of averaging 489 days per month. They had utilized bed days of 382 per month. So that is an average of 78% of the available beds were used between May and November, if that makes it, just a little bit simpler in terms of being able to offer some of those. So great numbers, to be honest, a real high utilization, and certainly the Crisis Stabilization Center Advisory Committee and some of the other subgroups are talking about, wow, what do we do with this success? Because if law enforcement, as Sheriff Elfo made reference to, comes out and we're at full capacity, well, we're struggling with a great problem to struggle with, but nonetheless, we want to be able to admit the right people. That is those diverting, and certainly a priority for law enforcement drop-offs in particular. And so that's our goal in 2022. So just to clarify in terms of the detox numbers, in terms of the mental health stabilization, Compass Health being the provider, they had a total of 650 referrals between May and November 2021. And again, what the outcome of that particular referral was, there's a number of different categories that it can fall into, but they had an average of 358 available program bed days because of staffing numbers and a variety of sort of other reasons, but they had a lower number of average bed days. That's basically the number of days available, during the month times 16. And then the average utilization of the available bed days was 226, which comes out to a 65% average in terms of utilization of available bed days for the mental health stabilization side. So again, hopefully that clarifies, some of the questions with enough detail that that it makes more sense, sort of where I'm coming from, which is exactly the data that we're now utilizing as we've begun to compile this, because we didn't have the ability to compile this data initially, but gives us the opportunity to then focus in, obviously, on, okay, so what's happening? What do we need to do, or what can we do relative to streamlining the admission process, encouraging communication, a number of things that I won't go into all that detail, but it gives us a very clear, I think anyway, a very clear picture of what do we need to be focusing on to increase that utilization. My goal being that that we're predominantly at capacity, and that is the problem. I'd be more than happy to continue to address full capacity as being a problem.
Yeah, no, thank you for that coverage. I think that's good. Maybe at a future meeting, I think looking into referrals and seeing that difference between referrals made and actually accepted, and then just making sure that we've tightened up anywhere that we can in the process, so you're getting good referrals, and also then highlighting if there's any issues, because I know that there was some challenges. Perry, thank you so much again for sharing the information and all the spaces that you do. I really appreciate it. I know we're over time, so I'm going to stop.
Yeah. Mike's correct that we are at time right now, and we did not get through everything. This is a big body of work, and Mike, I think that you just brought up one of our next agenda items, and Perry, in terms of the referral success and such with the crisis stabilization. Understanding that the plan is now to go back to our respective committees at our next separate legal and justice system, separate behavioral health committee meeting. Have that meeting. I think there's maybe one or two in between the next joint, but I'm really looking forward to the next joint meeting and continuing this discussion. We had invited Chief Jones and Lieutenant Erickson from Vacant County Sheriff's Office and the jail to be a part of it. They couldn't make it today, but they had committed to making it to the next joint meeting. So So yeah, so we're at time. I want to allow for public comment. Raylene, did you have any other items real quick here before we close?
No, I think you wrapped it up nicely. Thank you.
Okay. All right, very good. Jill Nixon, do we have anyone who wants to speak from the public?
Thank you. We have 2 attendees to the meeting today. If either of you would like to speak to the committees, please virtually raise your hand now. No attendees' hands are raised.
Okay, I do see a panelist hand who is raised. Moonwater, do you want to go ahead?
I'm just going to say real quick, I don't know that we had as thorough of a conversation about reentry and where the gaps are. And so I'm looking forward to that conversation continuing in the new year. I know I'm stepping off the task force. I'm also continue to be interested in the intersection of restorative justice and reentry and this work. And so let me just name that, lob that out there. I'm especially interested, I'm hoping to follow up with Prosecutor Richie, Heather. I know that you've been in some conversation. I'm just naming it. Let's have that conversation in the new year. And however I can assist in keeping that moving forward, just as a community member, I would be interested in that. Thank you, everyone.
Thanks, Moonwater. And I would like to continue that discussion, pardon me, in the behavioral health subcommittee as it relates to all the vast constellation of issues and ideas around reentry. Okay, and if there's no further business before these joint committees, then we are adjourned. Thank you for being here. Have a good rest of your day.